This explainer is based on the literature review Ménière's disease, a vestibular physician's deep review of endolymphatic hydrops, diagnosis, and management, published by Australian Dizziness Clinics. It's available right now at australiandizzinessclinics.com. Welcome back to our audience of vestibular professionals. We're now on explainer 3 of our 6-part series, focusing on clinical features, the Bárány criteria, and investigations. So, here's the bottom line right up front. 2 or more spontaneous vertigo episodes in the 20-minute to 12-hour window plus low-frequency audiometric loss equals definite Ménière's. Today, we're really getting into the clinical weeds where this diagnosis is actually made in practice. Here is our roadmap for today. We're going to cover the classical symptom tetrad, the Bárány 2015 diagnostic criteria, high-yield audiometry, vestibular tests and dissociation, MRI and Hydrops imaging, and we'll wrap up with the key clinical takeaways.
Okay. Section 1. The classical symptom tetrad. We have to remember that Ménière's disease is, first and foremost, a clinical diagnosis that is deeply anchored in the patient's story.
The classical presentation breaks down into 4 really distinct quadrants. We have that episodic, intense rotational vertigo. We have fluctuating sensory neural hearing loss that, early on, usually just affects 1 year. Then there's that low-pitched, roaring tinnitus. And finally, the highly characteristic, though honestly often underreported, oral fullness. You'll frequently hear patients describe a crescendo of tinnitus and fullness that leads right into an attack.
Now, the crucial point here is the temporal window. The episodic nature of the vertigo is your single most important diagnostic anchor. Specifically, we're looking for episodes lasting anywhere from 20 minutes to 12 hours. Think about it. If it's just brief seconds, you're probably looking at BPVP. If it's continuous over several days, you should be thinking vestibular neuritis. But 20 minutes to 12 hours, that is your ultimate phenomenological anchor for Ménière's. Before we move on, we absolutely have to mention a really surprising and dangerous clinical reality. 5 to 10% of patients will actually experience Tumarkin's otolithic crises, which are often called drop attacks. These are sudden falls, completely without warning and without any loss of consciousness. They're attributed to a sudden mechanical disturbance in a hydropic utricle or saccule. These attacks are terrifying for the patient, highly disabling, and they demand aggressive vertigo control. Moving to Section 2, the Bárány 2015 diagnostic criteria. This is where we shift from the raw clinical presentation to the rigid rules of engagement embedded in the 2020 AAO-HNS guidelines. The current standard separates cases into 2 distinct tiers. For definite Ménière's, you absolutely require audiometrically documented sensory neural hearing loss in the low to mid frequencies. That's the main differentiator. Probable Ménière's, on the other hand, relies on fluctuating oral symptoms, but it doesn't strictly demand that audiometric documentation. And, of course, both tiers explicitly require that the symptoms aren't better accounted for by some other diagnosis. If you're familiar with the older 1995 criteria, you'll know that the 2015 update deliberately stripped out the vague, possible, and certain tiers. Why did they do that? To dramatically improve specificity. Possible Ménière's was notoriously just misdiagnosed migraine hiding in plain sight. Narrowing the vertigo duration to a strict 12-hour cap for definite Ménière's finally helped us filter out those protracted single events like vestibular neuritis. Let's look at Section 3, high-yield audiometry. We are now entering the objective truth phase of our diagnostic funnel, and we're starting with the single most mandatory investigation. There is a classic peak or upsloping pattern you'll see on real-world audiograms. The loss is predominantly in the low frequencies, right around 125 to 500 Hz, with relative preservation of the higher frequencies. This is a highly typical early-stage footprint in Ménière's disease.
I really want to drive home this clinical pearl today. Pure tone audiometry is mandatory at presentation because hearing actively fluctuates in early disease, often improving between attacks. Getting serial audiograms is vastly more informative than just taking a single snapshot in time. Now, over time, that peak loss will unfortunately progress to a flat loss, and speech discrimination will deteriorate disproportionately. But early on, capturing that fluctuation, that's diagnostic gold.
Section 4. Vestibular tests and dissociation. So how exactly do we objectively quantify ipsilateral weakness when that patient is sitting right in front of us in the lab?
Well, here is a truly fascinating clinical dissociation you definitely need to be aware of. You might find a unilateral caloric paresis, indicating a low-frequency canal weakness, but when you go and perform a video head impulse test, a vHIT, the response is completely normal. This vHIT normal caloric paretic dissociation is presumed to reflect preserved high-frequency canal function, and it's actually quite specific for endolymphatic hydrops.
So what about the other tests? VEMPs, which measure saccular and utricular function, can show tuning shifts that support a hydrops diagnosis. And electrocochleography, or ECOG, can reveal an elevated SP/AP ratio supporting cochlear hydrops. However, it's really important to remember that these only provide indirect evidence. Their sensitivity is pretty modest, and they're primarily adjuncts we use to characterize atypical cases or to establish a baseline. They do not replace your clinical criteria.
Section 5 brings us to MRI and Hydrops imaging. In modern practice, radiology serves a dual, incredibly critical purpose: strict exclusion and advanced confirmation.
Let me state this as forcefully as I can. An MRI of the internal auditory meatus with gadolinium is absolutely mandatory at a patient's first presentation. You simply must rule out structural mimics. A vestibular schwannoma or an endolymphatic sac tumor can completely mimic the full Ménière's phenotype, and these central pathologies absolutely must not be missed.
But the exciting part is that imaging is evolving rapidly. In expert centers, delayed 3D FLAIR MRI, which is performed about 4 hours post-contrast, is really shifting the paradigm. We are moving away from purely ruling out tumors to actually being able to directly visualize the endolymphatic compartments and confirm the presence of endolymphatic hydrops. It's a total game changer for those tricky atypical presentations.
Finally, Section 6, Key Clinical Takeaways. Let's distill all of this down to the actionable clinical pearls you need for your daily practice. To summarize our core diagnostic flow, first, respect that strict duration window. Anchor on the 20-minute to 12-hour episode of Vertigo. Second, rely heavily on mandatory, serial pure-tone audiometry to catch that early low-frequency fluctuation. Third, always order an MRI of the IAM with gadolinium to exclude structural mimics. And fourth, keep in mind that over-investigation rarely changes patient management. Order those vestibular tests only when you have a specific clinical question in mind. I want to leave you with a provocative thought here. Diagnostic momentum is a dangerous thing. If a patient's presentation doesn't fully fit, like if the vertigo only lasts seconds, or if it stretches continuously over 48 hours, are you truly dealing with Ménière's? Atypical presentations, or those quote-unquote refractory cases, very often hide a misdiagnosed condition, and most frequently, that's vestibular migraine. Always be prepared to reintegrate your differential. And that actually sets up our next topic perfectly. In Explainer 4, we'll cover differential diagnosis in detail, focusing heavily on the Ménière's and vestibular migraine overlap. Parsing that overlap is arguably the single most consequential diagnostic decision in modern Ménière's practice. You definitely won't want to miss it. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this Explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series. Thanks for joining me.